I think we'll get started. Welcome, everybody. We are so excited to have such a large crowd, and we do have some new participants. This time, we have these calls weekly, so welcome. And PMP PALS is the oldest global support group for patients with appendix cancer and PMP. So we're proud of our heritage. We were founded in 1998 by Gabriella Graham. Sadly, Gabriella passed away in 2014. And so, a few of us have, relaunched PMP PALS back in 2015, and I'm happy to carry on her legacy. So my name's Adele Jason, a patient. I'm coming up on 9 years since my CRS HIPEC at UPMC, and also the vice president of our board. A familiar face to those of you on this call is Chris Piekarski. Chris, I'll let you tell everybody your lengthy time.
And Good morning, everyone. Good afternoon. It's great to see everybody. We're super excited to have you here, just like every week. We hope you'll find this presentation informative, and we hope you'll engage with us. Feel free to send questions while the program continues to zoom@pmppals.net. I will be monitoring that throughout the presentation, but we're super excited to have everybody. This is the highlight of my week, and I hope you enjoy it as much as I do too. Thanks, Adele.
Thanks, Chris. And as I mentioned, we're a group of volunteer patients and caregivers, and we have some other core members of our leadership group and board. And so we'll just ask them to give a wave to us. So Charmaine, Misty, we don't have your video out, but Misty runs our card program. Michael.
Hi, guys.
Hello. And then Connie is in there somewhere. And yeah. So again, due to the size, we won't have introductions. So, but we're glad you found us. We appreciate everyone going through the registration process. Registering for these calls really helps us be better prepared for you and do our planning. So much appreciated with everyone going through the registration process. Now I'm going to kick it over to Chris real quick, who'll just give us a few reminders before we get into the highlight of our call today.
Well, thank you, Adele. And, as Adele said, I wanted to share a few reminders with folks. Even though we've been doing this for quite some time, since 1998, it's important to remember we're not licensed professionals. We can give guidance and advice, and we do bring professionals to this conversation who are licensed to discuss medical care, but you need to seek your own team and your own licensed medical care. It's really important that you do that. That's really the purpose of our being here, just to get you to proper care. You do grant permission for your likeness to be shared by participating in this meeting. We will share this video with others because it's just valuable information that our community needs to see. You may see some graphic images today or some scary data, so please be aware of that. And then finally, while we try very hard to keep this form anonymous, we cannot guarantee that. And so your health information may end up being shared with the public. So please be aware of that. I would encourage people, you can change your name if that can help anonymize things. So that's one thing you can do. But just wanted to share some of these disclaimers, and very excited again to have you. Thanks, Adele.
All right, thanks, Chris. And so now we are so excited to have Dr. Choudry of the University of Pittsburgh Medical Center be our guest speaker this morning. Dr. Choudry is definitely an esteemed specialist in treating us. And for me personally, I have vivid memories of Dr. Choudry when I had my surgery at UPMC, as I said, almost 9 years ago, and it takes a team, and I remember him well, you know, just from being part of the team that did rounds when I was at Shadyside Hospital. So much appreciated. And Chris, I mentioned to Dr. Choudry, we have one of his biggest fans on the line. So I'm going to ask you to unmute Dave so that Dave can just say hi to Dr. Choudry before we begin. If that's okay with Dave, I assumed it would be.
We're going to put Dave on the spot. If I can find him, it's a huge crowd today. Yeah. And there's still more folks coming in too, but Dave, I'll find you in there somewhere.
Yeah.
There he is.
Can you hear me okay?
We sure can.
Can you hear me? Dr. Choudry.
Nice to see you.
You know me better than anybody on this planet.
And the inside, yeah.
We are intimately acquainted, and it's great to see you.
That's right. It's nice to see you. You look well.
I gained 50 pounds probably since the last time I saw you. Thank you. Your promise came true. I asked you if I would get this weight back. You said, yes, David, you'll get it back. So
it's so nice to see you.
It's great to see you. Thank you so much.
Very well.
Fantastic.
Okay.
You look good too, by the way, Dr. Choudry. A typical Saturday at the hospital doing your rounds.
Balder than before, that's all.
Great to see you. Thank you for being here.
Thank you.
Okay, well, with that, we are going to ask Dr. Choudry to share his screen and start his presentation, which is on, you know, the rationale for CRS, HIPEC, and other novel therapeutic strategies for the treatment of PMP.
Can you see
Perfect.
that?
Yes.
Perfect.
Yes.
All right, great. So it's such a wonderful opportunity, and I'm very, very excited to be here today. And I'd like to thank Adele and Chris and everyone on the team to, you know, allow me to be able to do this today. And obviously, I'm so happy that I can talk directly to you as patients, because obviously, you know, to us, you're the most important part of everything we do. I do feel PMP Pals is such a nice legacy of Gabriella. I think this forum provides such a great resource for patients, but also us as physicians in trying to treat this tough problem. And so, you know, the topic today I have is this Pseudomyxoma and rationale for site reductive surgery, and then talking about some novel therapeutics. And I spent some time thinking about what I should talk about, because I wanted to do something that I felt would be more helpful from your standpoint as patients. And so hopefully it's going to be a bit of a whirlwind tour through PMP today, going from the basics to what our standard of care is, to me what is exciting, what the novel therapies are, and what trials are potentially going on. And so I thought it's going to be maybe a little bit fast and maybe a little bit of a whirlwind, but I thought it'd be a nice review, and then I'd be happy to talk about any or answer any questions. So let's get started. The objectives for the webinar today, one is to give a brief overview of PMP, and then talk about the rationale behind what we do. So site reductive surgery, why we do it, and what the rationale for it is. And then talk about appropriate patient selection. What are the things we look at to decide how a patient will do from this kind of an operation? And then talk about some of the novel therapeutic strategies that are out there, and then what the rationale behind them are, and what are some of the ongoing clinical trials that may be of interest to you as patients with regards to PMP. Starting with the overview, from a clinical perspective, I think you're all aware that Pseudomyxoma peritonei, or PMP, is characterized by mucinous ascites and mucinous tumor nodules. So it's this gel-like material that is made by these cancer cells, which is very unique to this tumor. And it almost exclusively occurs from appendix cancers or mucinous appendix. So if you look at the natural history of this disease, it starts like this, as an unruptured appendix. The appendix is dilated, it's full of this gel-like mucus, but it hasn't ruptured at this point. And then what happens is it ruptures. So this, you can see the tumor right here, and then this gel-like mucus that is spewing out of the appendix. And then after that, it leads to what we call PMP or pseudomyxoma. And so this is the abdominal cavity. And this over here is the mucinous ascites, so just the fluid. And then you have this thick mucin-like tumor nodules that coat the abdominal cavity and the organs, so the bowel and the liver. They all get coated by this disease, and it's quite a challenge for you as patients and for us as physicians trying to treat this. And when you look at it pathologically under a microscope, or more than 50% of this tumor is made up of this mucus, so this gel-like material. And it's important to remember from a pathologic standpoint, when you see a physician and they talk about the grade or the aggressiveness of pathologically. So at one end of the spectrum on the left here are the low-grade tumors. So when you hear us talk about low-grade PMP, it's this grade 1 PMP. The crux of the problem here is often the mucus. They're very, very highly mucinous. There's a lot of mucinous material, and the cells are not that many. It's a very hypocellular disease. And the cells that are within it are often very benign, not very aggressive. They don't tend to be very invasive. So they're not as aggressive as some of the other tumors. And so what we see is this big mucinous tumors that coat everything in the abdominal cavity. It expands the abdominal cavity. You can see all this grayish material, which is all mucus that's filling the abdominal cavity. And on a microscope, it's mostly mucus with some of these benign or non-aggressive kind of cells. And so the crux of the problem here is this amount of mucus that's being produced. And then the other end of the spectrum is these high-grade tumors or the high-grade PMP. Here you also have mucus, but the problem here is the cells are very aggressive. You get these nodules that are made up of very aggressive, infiltrating, invasive cells that just invade all the organs and cause obstructions and really cause a lot of problems in the abdominal cavity. And you can see the scan looks very different. It's not this tremendous amount of mucus. It's more this infiltrated disease that just gets stuck and invades into organs. And under a microscope, there's not as much mucus, but there are a lot of these aggressive looking cells. So very different problems here. This one's highly mucinous. This is less so, and more, the problem is more the cells in the high-grade disease. And so when we as physicians think about treating it, and when we think about research and how to do the two ends of the spectrum in a very different way. Now, the standard of care, as you all know at this point, there are three components to it. One is cytoreductive surgery. So the idea here is to get all the macroscopic visible disease out of the abdomen. So this is before surgery, you have all this disease. And this is after surgery. You can see a pristine blood supply to the bowel. This is bowel without any disease on it. And so that's the aim here, is to get all this macroscopic disease out so that there's nothing visible. And then the next step after that is to do the HIPEC, where we put heated chemotherapy, very high doses of it, which would be severely toxic if we gave it into your veins. But we give it directly into the abdominal cavity, trying to get rid of any of the microscopic disease that's left behind. And so there's a circuit we use to do that. And then the third component is chemotherapy. So this is IV or systemic chemotherapy. And that really applies to the higher grade, the grade 2 and the grade 3 cancers. It's not really effective against the low grade appendix cancers. And so this is the standard of care. This is the treatments that we will use trying to get the best results. And doing this standard of care, if you look at some of the data that's out there, this is some of the data from the University of Pittsburgh. Again, when I show this data, I'm always wary about giving numbers to patients. So I don't want you to take this as definitive numbers. These are averages. Every patient is different. None of us can really predict what will happen. But to give average numbers, if you look at survival, so overall survival is how long a patient will potentially survive after we do these operations. We can get very long-term survival. So if you take a grade 1 low-grade tumor, as you see in this graph, we don't reach the median survival. It's over 15 years as an average. And so patients do very, very well. When you come to grade 2 tumors, the survival does go down. We're talking about average survivals of 5 years. But again, there's a huge range in that. So these are not absolute numbers. And then the grade 3s are obviously a bigger problem for us, where survivals are not as good. And so it's still a big problem that we have to face. The other end of this we have to keep in mind is that even if we can get good survivals, the problem with anything we do is the recurrence. No matter how hard we try, and no matter what we do, these tumors tend to come back. The same thing, if you look at the grade 1 tumors, we're looking at 5 years and upwards when we start seeing most patients or half of the patients recurring. Whereas for grade 2 tumors, around 1.5 to 2 years is when we'll start seeing these or see a lot of these tumors recur. And then for a higher grade tumors, it tends to recur even earlier. And so that's the problem. No matter, even with the standard of care at this point, we're still struggling with recurrence and having to do these operations more than once. And so having gone through that, what I wanted to next talk about is why we do what we do. So what is the rationale behind the CRS and HIPEC? And so I'll give you a few concepts that give you a sense for why we do it. So concept number 1 is that cytoreductive surgery, or CRS, is feasible because the abdominal cavity is enclosed by a natural barrier called the peritoneal membrane. So within the abdomen, there's this lining called the peritoneal membrane, which keeps the tumor within this cavity, doesn't allow it to get out, at least in the beginning. And secondly, it allows the surgeon to have a plane of dissection, so we can get outside this membrane and then remove all the tumor in one go. And so this picture shows you that the purple line here is actually that peritoneal lining that encloses a cavity within your abdominal cavity. And so the tumor spreads within this. And so if we resect outside this peritoneal lining, we can get all that disease out in a very systematic fashion and try and get a complete resection and thereby reduce the risk of recurrence. So even though this CAT scan looks quite frightening and concerning, done with a lot of mucinous material, if you follow that basic principle, we can clean resection on patients, especially when they're low-grade tumors. So that's concept 1. The problem becomes is when we have disease that's going out of the peritoneal membrane. So when you have abdominal wall involvement, retroperitoneum, so involvement in the vessels at the back, or the lymph nodes, or involvement outside that peritoneal membrane, or systemically into the liver or the lungs, that's when we have trouble, and cytoreduction doesn't do as well, and that's where chemo plays a bigger role. Concept number 2 is that cytoreductive surgery is not a cherry-picking operation. We're not just taking out some disease and leaving disease. At least that's the aim. It's a very systematic approach to try to get all the gross disease or all the disease out. And so what we want to do is, this is before the operation, where you can see all these little nodules that are basically sitting on the peritoneal cavity. And that's what you want afterwards, where it's basically a very clean abdomen where everything has been resected and you don't see any of these tumors. And that's because we can get that whole peritoneal lining out of the abdominal cavity. Concept number 3 is HIPEC is feasible because that peritoneal membrane allows us to give very high doses of chemo into the abdomen without causing too much toxicity in the blood. So it's like a barrier that keeps the chemotherapy within the abdominal cavity. And this is just a pictorial representation. So this is a patient given mitomycin, which is a common the drug on the left side, and this is the time. And so when we give the drug in the abdominal cavity, you can see the drug concentration remains very high in the abdominal cavity. Very little of it, as shown here, gets into the blood, this line. And whatever does get into the blood gets excreted out the urine. And so that's why we can give much, much higher doses of chemotherapy that would be very toxic if given in the veins. And it stays in there and it has a good effect on the tumor. And so that's the rationale for giving HIPEC. And then the concept number 4 is that despite my saying that HIPEC works very well, it stays in the abdominal cavity, The problem is the drug doesn't penetrate very well. It will only penetrate about 2 to 3 millimeters into the tumors. So there is a drawback here. And that's what's shown here pictorially. So if you consider this as a tumor nodule sitting in the abdominal cavity, and this is the surface of the tumor, and this is 3 millimeters into the tumor, the drug, as seen by this line, rapidly goes down. So as it goes through the tumor. So at about 2.5 millimeters, there's very little drug getting past that. And so that's the drawback. And that is the reason when surgeons say we want to get a complete resection down to what's called a CC1 resection, where we're getting tumors down to less than 2.5 millimeters, that is the whole reason. If we can surgically get your tumor down to either 0 disease or tumor size of less than 2.5 millimeters, then we can rely on the chemotherapy to do the rest of the job. And that's why we have that combination of cytoreductive surgery and then HIPEC to try and kill these tumors. Concept number 5 is that heat kills cancer directly, but it also augments chemotherapy. So it works in 2 different ways. As you go from a temperature of 37 all the way up above 42, 43, cancer cells, as shown on this line here, just start dying rapidly. And 42 seems to be that sweet spot where it's not causing too much toxicity to your normal cells, and it's causing a lot of toxicity to the cancer cells. And so that's why when we do HIPEC, we tend to do HIPEC at 42 degrees centigrade for about 100 minutes, because that's where we see the maximum, or at least the majority of the effect happening. We need to get the chemo and the heat in there for at least about 90 to 100 minutes to get that maximum cell kill. So that's the second part of the talk that I wanted to explain, and that was about the concepts. And then the third part I wanted to just quickly go through is what is appropriate patient selection? What are the factors that we're looking at to decide who is going to really benefit from the operation and who may not benefit from the operation? And obviously, when you're looking at that, we have to look at research and what patients have been through and how they've done. And then we look at those factors that seem to make a difference. And so there are tumor-related factors. So cancers like appendix might do much better than cancers like gastric cancer. And so the histology matters. The grade, like we talked about, a low-grade tumor tends to do much better than a high-grade tumor. The amount of disease you have in the abdominal cavity, which is called your peritoneal cancer index, is very important. The more disease you have, the harder it is to achieve a good resection. And so earlier, the better. And then other things like lymph nodes and molecular factors and genetic factors of the tumor do play a role. Secondly is the treatment. So how well can we resect the tumor, the completeness of resection? The more that we can take out, the better, obviously. Post-operative complications, the less complications we have, the better. And that's a hard one because these are tough operations for the physicians and tough operations for patients, but complications do matter. How you respond to chemo is a big thing as well. And then finally, obviously, we need to have a patient who is healthy enough to tolerate these procedures. And so if you look at any data, patients with appendix cancer will do better than patients with colon cancer in general. Patients with low-grade disease, grade 1, will do better than high-grade disease, grade 3. This is for appendix cancer. Patients with low tumor volume, up here in blue, will always do better than patients with high tumor volume in red. Patients who have a complete resection here in blue will always do better than patients who get an incomplete resection. And so it just shows that we have to keep all these things in mind when we decide how aggressive we should be, when we operate, who to operate on, so we can get the maximum benefit without hurting patients. So going through, after all that, there are obviously flaws to what we do. And the flaws are, one, as I showed you, disease recurrence is a problem. No matter what we do, we have problems with recurrence. There's significant morbidity to what we do, and patients often will suffer from these procedures. Limited chemotherapy, we do have chemo, but there's a limited effectiveness and limited options. There are not a lot of targeted therapies, meaning honing in on the specifics of a cancer and trying to treat the cancer specifically. And then there's limited funding and research just because of the rarity of this tumor. And that's why forums like PMP Pals are so important, because I always love this quote where rare diseases are rare, but rare disease patients are numerous. And so we have to keep doing the research. And so now I'll quickly move on to the novel therapies, the rationale of these novel therapies, and what are the potential ongoing clinical trials that are out there and up and coming. So the first one I want to talk about is mucolytic therapies. To me, this is an exciting research avenue and an exciting therapeutic avenue. So mucolytic therapy basically means looking for drugs that will dissolve or destroy that gel, that mucus. And so the rationale here, as we've already seen, is that there's a lot of mucus being produced in PMP, and this mucus causes significant problems. It compresses the organs, causes organ dysfunction, it's hard to eat, it causes pain, and then it also covers the cancer cells and protects the cancer cells from the chemotherapy getting to them. And so it protects the cancer cells from being killed by chemotherapy. And so if we have drugs that can dissolve this mucus, it could really benefit patients. And so this is what I'm saying. If we have this sitting in the abdomen and coating the cells, it is hard to get through this. And this is what mucus looks under an electron microscope. So on high resolution electron microscopy, it looks like this lattice structure that is coating the cells, and it's hard to get anything to go through this. And so this is some of the research that my lab here at Pittsburgh and Dr. Morris in Australia have been working on, this combination of bromelain and N-acetylcysteine. So bromelain is extracted from pineapples. It's a protease that eats up proteins. And N-acetylcysteine we get this from onions, and it also breaks up bonds that are in the mucus. And so this combination has been quite effective. And to show you that, this is research from my lab. This is a sample from one of our patients with PMP. This is untreated mucus. This is treated with bromelain, doesn't do too much on its own. This is N-acetylcysteine, again, doesn't do too much on its own. But when you combine it, within 2 hours, it's all liquid. And that's what we're trying to achieve here. And this is just a protein Western blot. It looks at the protein. You can see with untreated versus treated, the protein's completely destroyed. And that's what we're trying to achieve here. And in fact, Dr. Morris in Australia, before I go on to that, this is animal studies from my lab as well at Pittsburgh, using the same combination in a rat model. So we take mucinous tumors from one of our patients, we implanted it in a rat and developed a PMP model. So this is the inside after sacrificing a rat after 5 weeks of no treatment on the left here and treatment on the right. And you can see this heavy mucinous disease in the abdominal cavity that's coating all the organs. And this is an MRI. This white structure right here is all mucinous tumor that you can see right here. And this is after 5 weeks of treatment. It's mostly fluid with a little bit of mucus, and the MRI shows just this little bit of tumor here. So quite a dramatic effect we're seeing in the animal models. And this is just a pictorial representation of that. And so going on to the trial, actually Dr. Morris in Australia ran a early phase 1 trial with 20 patients and put catheters into pockets of mucus or in the abdominal cavity and gave patients bromelain plus N-acetylcysteine, this combination. And this is some of the results from his trial. So on the left here is one patient, and this right is a different patient. And up here is untreated, and down here is treated. So catheter was put into this mucus pocket right here, given bromelain N-acetylcysteine, and on the next image you can see it's about half the size. And the same here, this is in the subcutaneous tissue under the skin, mucinous tumor sitting there, and then after treatment with this combination, it's pretty much gone away. And so very promising results. This is in the abdominal cavity. This gray material here is all mucinous tumor or mucinous ascites, and after treating it with a catheter, all that gray material has gone away. And so very exciting data from him. And that leads to 2 trials. So Dr. Morris is actually opening this trial that he did in Australia over here in the US later this year. And there'll be a few institutions, including ours, that will be involved. And this will be an early phase 1/2 trial giving bromelain and N-acetylcysteine either intratumorally, directly into mucin, or into the abdominal cavity, looking to see if we can get an effective response. And then we'll be starting a similar trial here at UPMC with the same drug regimen, but given slightly differently, where we're going to be giving it directly into the abdominal cavity over a prolonged period of time for about 5 weeks, 6 weeks, to see if we can get a prolonged response with this combination. And both of these trials should be opening up later this year. So very exciting. The second novel therapy to think about is molecular targeted therapies. So targeted therapies, just to give you an understanding, every tumor has specific genetic mutations and molecular abnormalities. So cancer pathways become activated because of some genetic mutations. Now, some mutations we can target and some we can't. But that's where research comes in, trying to figure out what are the genetic mutations that we can potentially target. And so if we look at mucinous tumors like PMP, we already have a fair amount of data. And the main mutations we're seeing are RAS mutations, GNAS, and P53. You may have heard these terms, but we're still a long way from fully understanding these tumors, but we are getting there. And the key here is if we can find targeted therapies to try and manipulate or slow down these tumors. And this is not meant for you to read, but just to show you that the signaling pathway of these cancers is so complicated, and this is just a simplified version of that, to see if we can target these various pathways with targeted drugs to try and slow down these tumors. And so in that vein, there are a couple of potential trials out there right now. One is a multi-institutional trial called the MATCH trial. It's a phase 2, so an early phase trial. They basically take patients' tumors, run genetics on it, figure out if they have any of these particular mutations that I have mentioned, or that I have written here, and there are known drugs that will target these mutations. And so if your tumor has these, you could potentially be on a trial to try and target these tumors. This is a phase 2 trial. And another similar trial is through Genentech. It's a My Pathway trial, again, a phase 2 trial of drugs. Same concept as genetically mapping the tumor of a patient and then looking for specific mutations that we have drugs for to try and slow these tumors down. So another novel therapeutic strategies that is in trials at the moment. The third novel therapy I want to talk about is immunotherapy. So I'm sure everyone here has heard the term immunotherapy, and it's been around for decades and it's had its ups and downs. And recently with melanoma, we've had tremendous improvements in patient survival. And so it's a hot topic and a hot area of research. And so the basic rationale for immunotherapy is we all have an immune system that normally is killing off cells that could become cancers, but sometimes cancers evade the immune system to get around it, and then the immune system can't fight them off and these cancers continue to grow. And so the objective of immunotherapy is to harness the patient's own immune system to fight the cancer. So we're trying to activate the immune system. And so if you look at PMP, this is a pathology slide. All these blue dots are immune cells. So we know they're infiltrated with immune cells. What we don't know is how well they work, and if they don't work, why are they not working? And that's what the aim of a lot of research is. And if you look at immunotherapy, there are 4 big arms. There's vaccines, there's immune checkpoint inhibitors, there's oncolytic viral therapy, and there's adoptive cell therapy. Those are the big 4 arms. And again, my objective here is mostly to just familiarize you with what's out there, and why I'm talking about these is because there are potential trials for these. And so these are the big 4 arms of immunotherapy that I would mention. The vaccines are mostly in a preventative prophylactic setting, but these other 3 are in a treatment setting. And so to start with immune checkpoint modulation. So immune checkpoint inhibitors are basically, if you take an immune cell like a T cell, which is a cancer fighting cell, it is activated or inhibited by a lot of different molecules. And again, it's very complex in that all these different molecules are either activating or inactivating your immune cell. And so if we either inhibit an inhibitor of an immune cell, or we activate an activator of an immune cell, we could enhance the activity of an immune cell. And that's the objective of our immunotherapies. We're trying to supercharge our immune cells to fight cancers. And the reason I list these few molecules is because these are involved in clinical trials that could potentially apply to you. And so these are a couple of trials that are ongoing. At the University of Pennsylvania, they're recruiting in a phase 2 trial, immune checkpoint inhibitors, patients who could potentially be on immune checkpoint inhibitors. And similarly, there's one through GlaxoSmithKline through multiple institutions, phase 1s or early phase trials, looking at, these are activator molecules for T cells or for immune cells. And so they're trying these molecules along with the other immune checkpoint inhibitors to try and supercharge or activate that we could, patients with DMD could potentially get onto. So that we actually T cells or their immune cells, we will genetically re-engineer them to again supercharge them and then give them back to a patient. So you take your own T cell, you change it slightly, and you give it back to the patient so that they can fight cancer. And one of the ones you may have heard of is called CAR T cell. It's basically the same concept, is taking your T cell and modulating it or manipulating it to fight cancer. And just to give you an idea of that, Dr. Katz is well known in immunotherapy, a surgeon, and he is doing a lot of this immunotherapy research for intraperitoneal delivery, so giving it into the abdominal cavity. And this is one of his studies looking at a mouse model of colon cancer. And he gives these CAR T cells to the mice in the abdomen. So this line here, so just to orient you, this line here tells you the burden of tumor, so how much tumor there is. This is an untreated mouse. There's a fair amount of tumor. This is CAR T cell given in the veins of the mouse, so significant drop in tumor. This is CAR T cell given into the abdomen of the mouse, almost a much bigger effect on the tumor. And then this is if you give the CAR T cell along with the checkpoint inhibitor, the one I showed you before, if you give them together, you're having an even bigger response. So this is a mouse, a picture, this is a fluorescence image of a tumor in a mouse. You can see a lot of tumor. This one over here is the CAR T cell, so you have a very small tumor. And then this one over here is a CAR T cell plus your immune checkpoint inhibition where you cannot see the tumor anymore. So a dramatic effect of these treatment. And so he is running a clinical trial out of Roger Williams at the moment of using these CAR T cells to try and kill cancer cells, and it's an early phase trial at Roger Williams. So another potential trial that's out there. Another avenue of immunotherapy is called oncolytic viral therapy. So this is the rationale here is you're actually using viruses and you genetically engineer these viruses so they don't hurt you, but they will hurt the cancer by activating your immune cells. And so this is work of Dr. Bartlett. You all know him, I'm sure you all know him very well. He was here until recently, and this is some of his work. He's very well known in viral therapy. And so he uses a vaccinia virus, which is a form of a pox virus that does not hurt humans anymore, but it's genetically engineered to go directly to cancer cells without hurting normal cells. And it expresses IL-2. IL-2 is a very powerful immune activator. And so this is data from his lab where he took a mouse model of colon cancer. Normally, if you put colon cancer in a mouse, shown by this blue line, within a week or two, they all die. But if you give them this virus expressing IL-2, shown here with the green line and the red line, they're alive 150 days out, which is tremendous. And then if you give the virus with the immune checkpoint inhibitor, the one I mentioned a few slides ago, again, this is the untreated mice. This is the virus alone, and this is the virus plus the immune checkpoint. They are live, they're pretty much cured. It's very exciting results, but obviously we have to be a little careful because this is preclinical and animal models. But based on that, there are a couple of trials. So Dr. Bartlett and I will be running a trial out of Pittsburgh here starting later this year. It's going to be the same virus in an early phase setting given intra-abdominally into the peritoneal cavity and will include appendix cancer patients, but unfortunately not for mucinous cancers at the moment, but it will include non-mucinous appendix and colon cancers. And the hope is to get this type of efficacy with this treatment. The next thing I'm going to quickly talk about is nanomedicine. I'm going to talk about one or two more, and then I'll stop so we can get to questions. So nanomedicine is another very exciting field where we're taking nanoparticles. This is nanotechnology where we take particles that are very, very small, the size of antibodies and viruses, and we join them with chemotherapeutic drugs so we can stabilize the drugs, improve the efficacy of the drug, improve the ability of the drug to stay within the abdominal cavity, to penetrate through tumors. And there's tremendous amount of work going on with nanotherapies at the moment. And just to give you an example, at Stony Brook, they're doing a phase 1 study of a nanoparticle formulation of irinotecan to try and see if it's more effective than the wild drug or the drug without nanoparticles on it. And so this is just to give you a sense for what's coming down the pike. But there is at least this one trial out there. It's an early phase trial, but it's interesting, and there's tremendous amount of research going into nanomedicines. The last one I'll talk about is HIPEC, which again something you may have heard about. It's called pressurized intraperitoneal aerosolized chemotherapy. So this is somewhat like HIPEC, except what we do is we aerosolize the therapeutic drug, so make it into little microparticles, and then under high pressure it's given into the abdominal cavity. And the rationale is that we can get better circulation into or distribution into the peritoneal cavity and better penetration into the tumors. And there's not any trial open in the US, but there's a lot of research going on in Europe with multiple centers doing trials with HIPEC at the moment. And right now it's mostly used for unresectable situations for patients who are not eligible for HIPEC. But again, something that's very exciting and potential for research and therapy down the line. I'm going to stop there. There are a few other trials in the US, which I can give to Adele, and so that you have that. But I'll stop there. I'd like to thank you so much for letting me speak. It's a pleasure and it's an honor to be able to speak to you, and I'd be happy to take questions.
Well, thank you, Dr. Choudry. It's our honor to have you as one of our guest presenters, and really all the discussions, particularly on the novel strategies, just continue to give us hope. I mean, we know the medical community is working tirelessly, all for the best interest of our patient community. So we appreciate that. So a few questions that have come in. One of the questions is, what is the best type of chemotherapy to be used with HIPEC?
So to start from the beginning, as physicians, when we pick a chemotherapeutic agent, we're looking for certain features about a drug. So, a drug has to be something that will stay within the peritoneal cavity without causing too much toxicity. So you want a drug that has a high molecular weight. You want a drug that's charged so it doesn't cross the membrane too easily. You want a drug that is augmented by heat. So if you give heat with it, it's more effective. So those are some of the characteristics that we look for in drugs. Now, for appendix cancer, generally we'll use a drug called mitomycin because it fits almost all of those categories. But you can use other drugs. You can use things like oxaliplatin, which is more commonly used in Europe. But generally, the go-to drug for intraperitoneal delivery for mucinous tumors and for PMP is often mitomycin, and that's our go-to drug here in the at UPMC. So you want high concentrations in the abdomen with limited systemic toxicity.
Thank you. Another question, does the type of diagnostic imaging used depend upon the diagnosis? Is CT with contrast the best? And I know on other sessions, you know, we've had discussions on MRI, CT, et cetera. Could you comment on the diagnostic imaging?
Yeah, the big modalities that we'll use are CT with contrast. That's an excellent modality to use. It gives you pretty much everything you need to know. MRIs with contrast, MRI, when we do it, it has to be a very specific MRI. So it's a gadolinium enhanced MRI. It's a diffusion weighted MRI. So that's the technical terms for it. And it is in certain situations, also especially in mucinous tumors, it is a very good modality to use. And so when we can, we will use MRIs, but we have to be careful that it's done at centers that are used to doing MRIs and do this very specific, what's called a peritoneal protocol, so that we can get the pictures we need. Very important to remember that MRIs are finicky. MRIs are very dependent on the way you get them done. And so unless you're doing it at an institution where they do a lot of MRIs and they do this protocol, I would stick to a CT contrast, which is almost as good. But there is data, as I said, showing that MRI may be slightly better for some situations like mucinous tumors. But the go-to, if you don't have those facilities, is a contrast CT. PET scans don't add much to what we do these kinds of tumors. It's more if you're looking for metastases outside the abdominal cavity or liver metastases or systemic metastases, but otherwise doesn't add too much to what we to these kinds of tumors.
Okay. Could you speak to the impact of COVID on treatment and surgery?
Yes, it has been a big concern for us. In fact, as a group through the SSO, there were a number of discussions and guidelines that were put out because obviously it was a big concern. We did try and minimize what, when we were in the height, or at least the first height of it, we did try and minimize and not do HIPECs if we could. And so patients who could be delayed by giving more chemotherapy, we were trying to do that. People who had lower grade disease where it wasn't we had time that we could wait, we were trying to avoid them. But obviously we didn't avoid it if we had to do it. We do feel that with the COVID, given that it's such a big operation and it does immunocompromise patients, we did want to avoid doing it because the risks of developing COVID after a HIPEC would put a patient in significant jeopardy. And similarly, the HIPEC portion of it does immunocompromise you, and so we wanted to avoid that. So yes, big issue for us, a lot of discussions. Most centers put off CRS HIPEC as long as we could, but we have restarted once we felt, and the institutions and the states felt it was safe enough to move ahead. I think we're in a bit of a position now where we're all worried again, and we're going to have to think about what we do in the near future.
Yes, challenging time for all of us. On some of the novel strategies, how do patients sign up or get connected? What is the process for being eligible and pursuing one of these strategies?
Sure. So I'm always available. So if you have questions, etc., I'm always available, and I'm happy to take emails to help direct people. But But the bigger thing would be, you can go on websites like clinicaltrials.gov. And on this presentation, I listed all the NCT numbers. So that's why I put them on there, because all you have to do is type in that NCT number in clinicaltrials.gov, and it will take you straight to that trial. And if you look under that trial, then you will always find a phone number that you can contact. And also on my presentation, I put the institution and, if I could, the name of the PI. And so I would say those are your best options. Go to clinicaltrials.gov, type in those numbers. You can call that institution. There'll be a number on clinicaltrials.gov, and you can just ask, and then they'll get you directed directed to the right person. And if you can't, then it's your medical oncologist is a great resource. Your surgical oncologist is a great resource. And if not, you can always, email one of us, and we're always happy to help.
Thank you. If the tumors are retroperitoneal and surgery would be risky, is systemic chemo something to consider?
So the thing I want to preface this whole talk today by, I should have prefaced it, but there are a lot of nuances to everything. So pretty much everything I talked about has nuances to it. And so it's very important that if you have this disease, these are discussed by multiple people. So obviously your medical oncologist, surgical oncologist, is very good to have a tumor board discussion about these cases, because every case is different and there are a lot of nuances. So when I say retroperitoneal extension, I don't want to take it as a blanket statement. Every retroperitoneal extension is a little bit different. So, if you have extensive involvement of the ureters on both sides, with obstructions of the ureters, those are usually bad, tougher signs of unresectable disease. If you have just a bit of extension into your muscles in the back, that can be taken care of surgically. If you have a lot of lymph node disease, that can be a problem. And so yes, under certain circumstances, like a lot of lymph node disease, a disease that's unresectable, that's where chemotherapy is unfortunately maybe the only way, maybe the only option, and we may not be able to operate. But other situations where it's involving the muscles at the back, or even the abdominal wall sometimes, there are often times when operations do make sense. So none of these are blanket statements. There's always going to be nuances.
Thank you. And one of our questions is to show the clinical trial numbers again, but we'll circulate the presentation so that everyone knows what those numbers are.
Sure.
Let's see. So we did have let's see, another question that had CRS and not HIPEC in a patient. And this is in the UK, so we'll ask our colleague Michael to weigh in if he wants to. So is there access to HIPEC for a patient that has only had CRS, or when is HIPEC an option?
So again, you have to have a lot of the specifics of a case. There are definitely situations where we would do CRS only and not do HIPEC. I don't know if that was, wherever this was done, whether it was because they didn't have access to HIPEC, or it may have been a conscious decision not to do HIPEC for a particular reason. So for example, patients who will have recurrent disease, very isolated disease, it often will not make sense to do HIPEC a second time. We'll go in, just do a surgical resection of that isolated recurrence. So there are good reasons sometimes where we will do cytoreduction only and avoid the HIPEC portion of it, because it does have some additional risk to it. And so that's the brief answer to that question. But there may be more to it that I don't know about. But yes, if someone has had cytoreduction only, but it potentially is eligible for HIPEC, it can potentially be done in a delayed fashion sometimes. That's also an option. But as I said, there are a lot of, I would have to know more about the case to give you a more definitive answer.
Okay. And I know you did put up some statistics, and we appreciate the word of caution, and from a patient perspective, we enjoy surprising the statistics every day, and so I think in our patient community, we really see the importance of the emotional resilience and the emotional support, and working hand in hand with the medical providers, for the best outcomes possible. And each case is different, and we encourage people to focus on their own individual situations.
I completely agree. That's why I was very careful to preface that slide, because even when I'm with patients, I'm very careful not to give numbers most of the time, because it is something that sticks in the mind. And I always say this is averages. There's a huge range that comes with that, and every patient is so different. So every patient has a different volume of disease, genetics of the disease, the type of disease, how well we can resect it, the pathophysiology of the person. There's just so many nuances that it's just to give you some benchmark kind of, but it absolutely doesn't refer to a particular patient. And we're also always surprised, and it's just so that we have some benchmark, but it doesn't absolutely in any way talk about a particular patient. This is population data.
Yes, absolutely. Well, and as you've also mentioned in your talk, as time marches on, these novel therapies, just continue to add to the hope for even better outcomes.
Yes, I mean, that's exactly why I thought I would talk about all these trials, because I know it may be too much data and sometimes may not be easy to follow. But I think you'll hear about these things, and I can imagine how you all do the research and you're all looking for novel therapies that are coming down the pike, and it's nice to at least hear about them, and it also gives you some background to the trials that you may be looking into. So I thought it would be a nice way to get you familiar with it.
No, absolutely. Okay. Yeah, I'm going to ask Chris, are you seeing any other questions?
I do see one more question. Thank you, Adele. So a patient asked a question. They had HIPEC in November and now are planning another surgery here in July. And I'll take the first whack at this, and obviously we'll ask for your insight too, Dr. Choudry. But we see patients do often, I should say at times, have to go through multiple HIPECs or multiple surgeries, especially in the early years, to get rid of the maximal amount of tumor. But we do often see patients do very well after that. So sometimes it takes a couple surgeries. My favorite story is the president of the ACPNP Research Foundation, who had HIPEC 3 times and changed the chemotherapeutic agent with Dr. Sardi across those 3 treatments too. So that's something we see. But Dr. Choudry, what's the UPMC experience there?
I completely agree, especially when you talk about low-grade tumors. Often it will take a number of HIPECs, and we've seen where we do one major HIPEC, but then it recurs relatively early, but then you get the second HIPEC, and then we don't see it for a long time. And so these are strange diseases, and often we have to deal with a lot of tumor the first time. Sometimes we'll do the first debulking and may not get everything that time because it may be too much for one go, and then we'll go back and do it at a second time, because you have to balance that benefit versus potential harm from these pretty tough operations on patients. So I completely agree. I would never. There's always potential for another operation. Here at UPMC, we have of the 1,900 or so cases we've done over the last 2 decades. We have done about maybe 150 to 200 repeat HIPECs, and most of them are 2 HIPECs in those 150 to 200. But we've done up to 5 HIPECs in one patient. And so it has to be, but again, we don't take it lightly. It has to be a patient-by-patient decision. things like the grade of the tumor and how fast it recurs and how it's responding to chemotherapy, or how the patient, what the physical status is. There's again a lot of things that go into making that decision. So again, tumor board discussions, multidisciplinary discussions, a lot goes into making those decisions. But yes, there's definitely situations where multiple HIPECs have done tremendous. And I also want to make sure I want to make sure I say that systemic chemotherapy plays a big role in all of this. So it's not all about the surgery. So our medical oncologists are a huge part of this, and it's a combined effort. So it's the surgeons and the medical oncologists and the pathologists, especially for PMP, the importance of a good pathologist and really understanding the tumor, what grade it is, and then it's the nutritionists and the palliative care specialists and staff. It's not one person in any way. It's a big team.
Well, Dr. Choudry, I will take a moment to give a shout out. And so I did work in oncology for a decade for Varian Medical Systems. They're the leader in radiation oncology around the world. And I had the pleasure of working with UPMC extensively on their integration with their electronic medical records. So my team integrated the ARIA system, which RADONC and MEDONC use with the EPIC system. So it really is a center of excellence. UPMC actually was the site that kept our team the busiest. So there's a lot of really good work done there. And I continue to say every time I see one of these presentations, and I am a 16-year patient, and I had the pleasure actually of spending a week as a caregiver with our founder, Gabriella Graham, at Shadyside. But I always learn something new, and I've got a lot of reading to do after this presentation today, because you've talked about a lot of really interesting options and hopeful options that each of us are really interested in. So thank you. But UPMC is a center of excellence, and I just want to encourage everyone here today and remind them that when we started the conversation, I said, in many ways, our entire job is to help get patients to centers of excellence. That's really what it's about. Centers like UPMC and others. The clinical information, the papers tell us that the experience of centers is significantly important. That centers should have done 130 to 140 HIPECs before they are really, really good at it. So again, we're glad to have experts like Dr. Choudry and institutions like UPMC and the expertise they bring to the conversation. So thank you, Dr. Choudry.
Yes, absolutely. We did have another question. Dr. Choudry, could you speak a little bit about post-op complications and what should patients do? I mean, oftentimes there's not a roadmap. You're used to getting 24/7 attention when you're in the hospital, and then when you leave, you're not quite sure how to judge if something's a serious complication or if it's just part of recovery.
Yes, I want to focus. I think we should focus on that. I think it's very, very important in the preoperative setting, and I try and do that to the best of my ability to make sure we really cover the magnitude of these operations and the potential for morbidity. At least 20 to 30% of patients will have a significant complication, whether that's bad wound infections or abscesses or leaks or pneumonias, or so there is a significant risk of having complications. But on the other hand, the mortality rate is relatively on the low side. So under 5% at least, preferably around 2 to 3% mortality from these operations. And if you can achieve those kinds of morbidity and mortality, that's on par with some of the other bigger operations like pancreas surgery and esophagectomies. And so we try and at least minimize complications. Now, obviously, yes, in the hospital, we keep a very close eye on things, but it gets hard when you leave the hospital. I think the key there is communication. It has to be. We have a whole we and other institutions have a whole outpatient staff to try and manage these things. So phone calls, emails, communication, anything. We like to know anything and everything doesn't seem right once a patient leaves the hospital. We'll often ask patients to stay in town. So after about an average of a 2-week hospital stay, we'll ask patients to stay in town for a few days at the family house so that they get used to being on the outside for a bit. Make sure there's no issues before they leave town, especially for our out-of-state patients, because it is scary and it's a worry when you're leaving town. So things like communication, making sure at our end we get everything that we need on an outpatient arranged, make sure we talk to your medical oncologist at that end, make sure we get you plugged back into your family care physicians, make sure there's an open line of communication. I think those are the best way to try and avoid issues once you leave the hospital. But it is a challenge, there's no question about it.
Okay, thank you. Yeah, I think those are the questions we have so far, but certainly if you do send us questions, we'll make sure to get those in Dr. Choudry's hands and give you a response. And then I think with that, again, thank you so much, Dr. Choudry. This was a fantastic presentation. And as part of our wrap up, Chris is just going to remind everybody of all of our programs that we have here at PMP PALS as part of the spectrum of supporting our patient community and giving all of us the best outcomes we can get. Chris?
Thank you, everyone. It was a pleasure. Thank you, Adele.
Oh, thank you, Dr. Choudry.
I'm always open to questions, so please.
Thank you. And as I mentioned, we will share the slides and your contact information, and we appreciate you being so open about connecting with all of us.
Well, this is great. So Dr. Choudry, again, my personal thanks for being here. And it's been a pleasure. And I know I've got my own work to do and do some research. Again, as Adele mentioned, we've been doing this since 1998. Our founder, Gabriella Graham, who you can find in that picture above, started what we do. And there's those of us who are here and thankful for what she did for us who are continuing this. But there's a number of programs that can be helpful to you. Now, each of us, I think, has a tendency to at times downplay where we are or perhaps not reach out for help. But I want you to know that we're here for you. The Get Well Cards program is one you'll never forget if you do sign up. Please just send an email. Tell us a bit about your situation. And Misty, who's on the phone today, will coordinate getting a box of cards to you. There's a picture of one patient who sent us a picture and the cards they received. You'll never forget it. You'll never forget the wave of love you feel from participating in that. Likewise, the Bare Bottom Bears program, Linda Abreu has been doing this since I've been involved with the organization for my 16 years. And I'd encourage you to reach out and get your Bare Bottom Bear, one that often has his own little gown and suffers some of the same things that we go through in the hospital. Additionally, ask Arthur. Arthur Reddig is a retired pediatric surgeon who is also a PMP patient. And again, while we can't give medical advice, sometimes the definitions can just be confusing. And sometimes we just need a sounding board. And Arthur would be more than happy to be that for you. So I'd encourage you to reach out to him. Finally, info@pmppalace.net is an email channel that we monitor, and we're happy to answer your questions, connect you with physicians or other patients as mentors if that's going to be helpful. And then finally, we're finding this hugely popular Zoom channel, and these Zoom meetings are really popular and people enjoy that. So you can always send questions there. We watch that every week, and we're really glad that we're here to be able to help.
Yeah, so with that, thank you again for joining. We'll publicize our next call, which will be next week, but we're so happy you're here. Dr. Choudry, thank you again. It was wonderful. And have a good weekend, everybody.
Take care. Bye.
Thanks, everybody. Have a great day.